Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
What is up, you guys? It is Erin Faules, one of the docs at Wild Health, here with Dr. Carl Seger, the Dr. Carl Seger, our CEO, a good friend of mine, a generally awesome human being. How's it going, Carl?
The Ohio State. Something. Isn't that how they pronounce it? Like if you're from Ohio State, you say the Ohio State. I don't know.
Yeah. Well, when you're not around, we always call you the Dr. Carl Seger. Yeah. No.
Well, So
Nice to have you on.
yeah, it's nice to be here. I guess we're gonna talk about I think this is actually when we talk about Healthspan, uh if I think of it as like things that your factors that limit Healthspan, and I kind of break that down in different areas. Everybody talks about this in different ways, but we're all talking about the same thing. The two factors that I am most fascinated and think about a lot is one is atherosclerosis. Yep, mostly, one, it's the number one. It's the winner chicken dinner. It still takes down most people in the world. And then I think about mental health, because mental health is it ends up like all the other sexy stuff we do ends up being the Trojan horse to talk about mental health. And it plays such a big role in everything we do. So I guess that's what we're talking about today. My two favorite things. I don't know if I'd say favorite, but most interested topics. I don't know how I'd say it, but
Well, I feel like the second one gets left out a lot in this conversation too. In terms of insulin resistance has been a really hot topic. For anyone who's listening who doesn't know what atherosclerosis is, plaques in the arteries of the heart disease, arterial disease of the heart, whatever you want to call it, is kind of the general way to look at this in layman's terms. But that's like the big, bad, ugly number one cause of death. People talk about cancer a lot. People talk about inflammation a lot, insulin resistance, dementia, some of these biggies. But mental health, you're not wrong, because not only is it linked to tons of badness in terms of all-cause mortality and all these other diseases being at higher risk by massive numbers, but if you don't have the motivation to make changes or take your meds or whatever else, it's going to exacerbate these other things for a number of less obvious and calculable reasons as well.
yeah, I mean, I think about like when people say mental health, it's like this catch-all, right? So, I think about it as the most common things we talk about is depression, anxiety, OCD. Maybe I'd even group ADHD and those sort of disorders in there. But depression and heart disease, cognitive decline, uh, yeah, I think even, and, I know even cancer risk, they all follow along. Now, whether one, it's a little chicken or egg there, but depression increases the risk of heart disease by twofold, or for earlier onset and worsening outcomes of heart disease, which is twofold that seems big, right? That seems like a lot. Um,
Enormous.
yeah, and then, at the same time you're talking about, I think there is this little people who develop heart disease, they you can be asymptomatic. So there's this trial, this PESA trial. It's the progression of early subclinical atherosclerosis. I really like this trial because it's looking at asymptomatic people between 40 and 54 years old. And they're looking at silent plaque and the relationship with other cognitive effects. So
Hmm.
you can show that there's a measurable drop in executive function scores, and you start to show early amyloid plaque with people with just or deposition in your brain, which can affect we don't have to talk about that now, but affects cognitive function. But, like, the idea that you're having these executive function changes when you're not having chest pain, you're not narrowing the significantly we're not talking about, like, you're not getting blood flow to your heart, we're talking about just plaque burden and the effects on your your ability to do anything, right? So, which seems pretty powerful to me, and you obviously, the leap to mental health there is not far, right?
For sure. And then I haven't like recently looked the statistic up, but I mean, we also know it's true that when there's any sort of, for other reasons, any sort of cardiovascular event, there's like a massive jump in depression and mental health disorders, which is kind of a little bit more intuitive, I think, because you're seeing like a look into your potential mortality when something like that happens. But there's just so much more over, I mean, which came first, the chicken or the egg? And in a lot of these ways, like, they both exacerbate one another, right?
Yeah. No, totally. And like, so there's medications that people get put on when they start to develop cardiovascular disease, which can lead to depression, right? And but then there's also the component of anxiety that follows that. But that is more intuitive. But I think there's also kind of on the front end thing that's less intuitive,
Mhm.
depression, like, and its role in the development of heart disease is probably what's more fascinating. That the association is there. There's certainly like physiologic thought processes. We can talk about that, but maybe we should talk about first is talk about what causes atherosclerosis, and then we can talk about like why we think that's associated with what mental health may be a contributor to that. Does that make sense?
Yeah, that sounds great, and also maybe what we can do about it, right?
No, we're just gonna
For anyone interested.
terrible. Don't do anything. Yeah,
Yeah.
yeah, yeah.
Yeah, perfect. So, I love it. So, what does cause atherosclerosis,
So,
Carl?
when I think about this, this is important because, it breaks down one treatment modalities, but it also, like, when we're talking about, like, mental health, why this plays a role in here. So,
Yeah.
we think about you have cholesterol, so you have a blood vessel tube, right? You have, your blood vessel, it's a tube, you have cholesterol inside it. You need cholesterol to live. You can't live without cholesterol, but certain types of cholesterol are more likely to infiltrate the side of a blood vessel wall, and you can have injury to that wall that increases the rate at which the cholesterol gets inside that wall, and then when it gets in there, it triggers this inflammatory response and immune response, and then that over time starts plaque formation, and you get more deposition. The inflammatory cells, the immune cells start to change, and you start to slowly produce this plaque, right? And it can even kind of like almost scar over and develop like calcium in it and deposits of calcium, and that's how you get that slowly narrows, and that can rupture and then clot off, and that when that happens suddenly, that's a heart attack or a stroke, right? It can also just slowly narrow over time. And what can happen with people is they get blood vessels that kind of develop around it. But and so you can kind of, bypass that area, but you still get narrowing of blood flow downstream, which can cause symptoms
Mhm.
where when people get chest pain, right? So, but the main thing is, so when you break that down, and you stand back from a process standpoint, it's the cholesterol and type of cholesterol that's in there, and the injury to the blood vessel wall, and then the inflammatory process. And all three of those things kind of guide on how we work with people to reduce plaque burden and actually reduce plaque volume, right, and stabilize plaque.
Mhm.
So that's how I think about how atherosclerosis works. Maybe
Yeah.
you, yeah,
Well,
maybe.
it's not a massive stress why depression would exacerbate that process, right? If there's, especially that inflammatory component. I mean, this is something that like I think about, which is super nerdy a lot, actually, which is the tie-in between our moods, our beliefs, our thoughts, and how that impacts our health of our immune system. I see a lot of autoimmunity here at Wild Health. And, our moods, thoughts, beliefs, etc., greatly impact both our nervous system and the function of our immune system, our levels of chronic inflammation, and our levels of oxidative stress. So basically, it just pisses off our immune system and suppresses the part of our immune system that protects us, and activates the part of our immune system that can cause kind of slow damage over time. So that makes a ton of sense why one would be correlating with the other just in terms of physiology. So and the data, pans out with that they exacerbate one another.
Yeah. So the thought process, right, is that you get this. You've probably talked about this on podcasts like HPA access, like hypercortisol state. Um, and that leads to low grade inflammation. And then also like this sympathetic overdrive, right? Where you're just kind of, you have increased heart rate, and you have that actually can lead to platelet reactivity. And then also that's involved with poor health behaviors in as a whole, like so, life choices. Um, and also leads to sleep disruption, right? And all of that we know lead to increased risk of
Feeds back.
yeah, feeds back.
Yeah.
Exactly. Yeah.
So
Real.
all of these things are connected. Um, cool. So, well, not cool, but what how often do we see this? What do we do about it? Like, what's the typical screening mechanism out there for this? Like, what are your thoughts on this? I know this is something you
Well,
think about a lot.
well, yeah, no, I think about coronary disease like all day, every day. But when I think about screening for coronary disease and then we can kinda get in treatment. When I get into treatment, that's when I start to bring in the aspect around mental health, right? As part of this. But when we're thinking about it from a screening modality, it's really interesting. So many people come to me and they have calcium scores, so coronary calcium scores, or, people just call them calcium scores, they'll call them CAC scores. I like, for lack of a better term, these things suck. Like, they absolutely drive me bonkers, and there's a couple reasons why, and I'll try to articulate that. Um, the other thing is people come to me as stress test. I remember this was about a year or 2 ago, and I had a patient who, like, I think, like, 6 months before he climbed Everest, and
Mm.
somebody did a stress test on him, and he came to me with, like, a normal stress test, and I was like, "Well, of course you have a normal stress test. You just
Your
climbed."
past life stress test.
The biggest stress test in the world, literally. You did fine,
Yeah.
job. But what but people and he was also a guy who came to me and had a coronary artery calcium score that was 0, okay? Well, coronary artery calcium scores, they have a 15% false negative rate. They're only talking to you about calcium, calcified disease. That So that is just one type of plaque, right? There's other types of plaque. There's non-calcified, and then there's low density. Low density being the highest risk. And so that guy, actually, we talk about it as an example, like, he ended up having plaque in his artery walls that was significant. When How we're evaluating that then is we're doing coronary artery CTAs. And we're specifically doing those and having them overread with using AI. We partner with a specific company. The company is called Clearly. We have had no affiliation with Clearly. It's Cleerly. I don't get any money from Clearly, but oh, it should, man. I should talk to those.
We make a lot of money for Clearly, I'm pretty sure.
They love Carl. Get the Carl. I'm like a warm blanket to them. But the reason we choose them is because, well, in my opinion, in what I say is everybody else is playing uh, checkers and they're playing chess. Although there are some newer companies that are coming out that are doing similar things, but we just really like what they've been doing. And what they're doing is they're using AI to look at the density in the plaque wall, right? And so they're able to define the things that we also care about. It's not just the type of plaque, the quality of the plaque, but in volume, but also the location. Like, location matters. Like, if you have a very tiny little narrowing at the distal area of your blood vessel, yeah, like, we're gonna do stuff about that. But that's not very common. What usually happens is you have a percentage narrowing of plaque formation at your left main artery. Well, that's a game changer, right? That's a different kind of party, because if that goes down, you almost go down instantly, right? That, one of the things I talk about with people, common the most common symptom presenting for a heart attack is still death. Like, that still happen it's the sudden rupture and clot off that we talked about before. And so you need coronary artery CTAs in addition to other, but the real question is when do we get those, right? So I'm interested in what you think about that.
Yeah. Well, I want to pause you for a second and just clarify. So, so Carl talked about a couple of different types of flax, the kind that kind of are less stable and more stable, essentially, is how I want people to be able to look at this. So the calcified plaques have typically been present for a long time. It's what you mentioned, kind of the slowly progressing, the slowly narrowing over time, tend to calcify and kind of harden and become more stable. Those can become problematic. They typically are the people that end up having chest pain and multi-vessel disease, like multiple vessels that are narrowed over time. And then when those very tiny vessels get even tinier, and then they start exercising or walking upstairs with groceries or whatever the thing is, they'll get short of breath. They'll get pressure in their chest. Those are the people that end up getting stress tests typically, right? And usually fail them because, again, they failed life stress tests, which I also use this with my patients. So it's funny to hear someone else doing that. Um, but these other plaques that typically don't have chest pain, that typically, may not typically, but more often than not, are going to present in a tragic way, like what you're talking about, are the kind of like dark horses, right? Like they are going to have would probably not show up on a calcium score because these plaques are softer or they are like less stable in nature. They're the low density plaques that you're talking about, and can suddenly rupture because they're less stable. So just as like a little background for people why that really matters, why we like super, super care about that 15% false negative rate, even though people get really excited, rightfully so, that they get a CAC score of 0. I look at it as kind of binary and worthless also, actually. So, anyway, so that's kind of a little bit of background about kind of why those two types matter. As far as when we should get these on people, I mean, the nature of the game with precision medicine is it totally depends, right? So who's at risk? I think everybody probably above 45. I think it's reasonable to say they should get one, if not earlier. There is some degree of radiation with this testing. It's a CT scan, you're getting contrast, so there's some risk. The CT scan is like the donut, the really quick test. So you don't have to stay still for a super long time like an MRI. But so most people have like seen or been familiarized with the donut image at least once, even on TV. But that's the kind of test we're talking about. And then it gets sent off for AI overread. I mean, we have patients that were getting these in their 30s for sure. Especially if they have big risk factors that we're screening for, right? Whether it's family history, whether it's lipoproteins being sky high, especially lipoprotein A or LP little a. If they have, really significant genetic risk factors like an ApoE44 or other cardiovascular risks in terms of their genetics, and there's some other reasons. But if people are checking off multiple of those boxes or even one significant box, I think it's a good reason to screen much earlier. That's my personal practice. But it's nuanced and it's based on data, right?
Yeah, so all those things you listed, I'd be interested. There's one thing I maybe split on a little bit, but I'm still kind of waiting to see. Is I in men at 45, I say all comers. Um, Earlier than that, it's all the risk factors you said. So anybody who has genetic history or family history, and I treat genetics differently. We do polygenic risk scoring on people and put them in. I'll have people who don't have much of family history, but they're really high from a polygenic risk score, and then they have like a high ApoB. That's somebody I'll scan earlier. Say I'm scanning at 40 or um, um, there's no like clear hard number. LP little a, I'm looking at ApoE4 genes, right? At 4/4s, we're talking about increased risk of dementia, but also the increased risk of cardiovascular disease is real. And so those people I'm scanning earlier for sure. In women, I what I have been doing in my practice, and this is something I'm like willing to change, is I've been kind of waiting to kind of perimenopausal, postmenopausal, um, I think I've interested you're probably way more knowledgeable about this than me, but I think there's a protective effect from estrogen.
For
Um,
sure.
Also less active breast tissue, and you're irradiating right at the breast tissue. And so the radiation dose, it's like less than 3 millisieverts. I live in Colorado. I probably get 9 millisieverts a year just living out here in Rocky Mountain High. Um, but um, like I don't think it's that huge a deal. But if it's somebody who's high risk and I'm gonna be scanning them earlier, like, cumulative over life, I'm probably gonna be scanning them a lot. So I don't know what you're doing male, female. Are you doing differences or no?
I It's a great question because it so depends on the person. I do think on average, I'm probably getting female scans later, but I have this question which I might not should be hashing this out in real time on a podcast, but I have this question all the time in my mind of like, what should our standard be here? Because atherosclerosis or these fatty streaks start so early with people. And shouldn't we know if someone's that person at 30 that has a significant early plaque burden, then we should be managing their lipoproteins much more aggressively than someone who is like the unicorn that at 45 has zero. So I don't know. I kind of wonder regularly if we should and I should be doing them earlier and earlier. I think you're correct. I think the average age of sudden cardiac death is still like 60s or 70s. So obviously, we're doing it significantly before that, but the evidence is pretty clear based on I mean, even for like tragic deaths of super early autopsies of people, this can start super, super young in people. And
Like,
um, you know,
there's like deaths of people who were killed by other reasons, and you
yeah.
can see flat burden in the early 20s for sure. Like,
Yeah.
those studies have been done. Yeah.
So I don't know. I have this question routinely. I think 40s for men and 50s for women is super reasonable because the question then that we're left with is if we see early plaque burden, what are we going to do about that in people in their 20s and 30s? If everything else looks good, it kind of again it will come back to other risk factors, right? And how high are those numbers? Because things like statins, things like Repatha or PCSK9 inhibitors, or what other tools we have, um, you know, it would just depend on the whole scenario. And we're already going to be doing other cardioprotective measures. We're going to be recommending certain exercises and sauna and all these other things. So
Yeah, I mean, I think it matters. Like, so, I mean, I'm interested. We could play a little game here. Is the
let's do
youngest
it.
person I've scanned is 32 that had significant plaque burden. So I've one dude in my patient panel. He's I think he might be 33 now, but he was 32 and he had like I think over 20% narrowing.
Hmm.
So like um
Wow.
yeah, like he had familial hypercholesterolemia. He was really
Yeah.
high polygenic risk scoring. Like he's a guy I was like, well, should I? And I felt like a little hesitant at 32. I had this like little pause that I was going to be judged by other providers. And then, like, that guy just made me go, "Okay, like, why am I pausing on this guy?" Like, I mean, after skiing, I should not be pausing on any of these people that we know, like, probably
Yeah.
yeah, um, but
And
I
so
right,
it's a great, yeah, it's great. I mean, because then it should at the very least be an informed decision if they act on those lipoproteins, right? And that allows it to be rather than a theoretic risk, that allows it to be like true risk and a truly informed decision at that point, what actions are taken.
totally, totally, but what's nice though now is we have the studies around when to repeat people, right? So we have the data around like, okay, if you have this much disease, we're aggressive about treatment, we're gonna repeat in a year, 2 years, 3 years. If you have no plaque, we're gonna repeat in 4 years, right? Because we know if you have no plaque, these are what has been interesting to me is these patients who have no plaque, who have really high risk factors, and what to do with them, and aggressively lowering ApoB in those patients. But that's a little bit outside of what we're talking about. But I definitely have like probably 5 or 6 people who have wildly high apolipoprotein Bs and cholesterol markers that are
Hmm.
like insanely high, and have familial hypercholesterolemia, who in their late 50s have 0 plaque, which is like doesn't make sense, right? But, like, they don't wanna have their cholesterol lowered. They're like, "Why would I do that?" And it's really hard to argue. I'm like, "It's a good point." But anyway, like, off subject. Um, yeah, so those risk factors and when to scan people, that's what I'm doing. I'm 45 and postmenopausal women, 45 and men. And then other risk factors earlier, basically. Yeah.
Yep. Yep. And, a lot of people unfortunately they don't know these other risk factors before they come to us or a similar type of medical practice. Unfortunately, a typical screening tool for this is going to be a cholesterol panel, which is, I wouldn't say entirely worthless,
Yeah.
but like
Kinda works.
not not as helpful, right? Like we
Would say, like, when people would get, like, a CBC, like, a blood count, you would say, "Yes, the lab values of the intellectually destitute." Yeah, that's how I feel about it. It's like,
Yes.
yeah, the plain cholesterol panel, okay.
Yeah. I will say like a resting EKG and a stress test in someone who's in their 30s, if they got that at their annual physical, is not something that I really care about. So anyway, getting the lipoproteins checked is super low hanging fruit, super cheap to do. If there's any concern, getting angiograms is also pretty easy. Pretty much most imaging centers have this, even if you can't get AI overread, you're still going to get a lot of data from that. Not quite as helpful as the AI overread, but still pretty dang good, and way more helpful than a CAC score or a calcium score. And that can give a lot of information. So, and should be on the top of most doctors' radars, if not all, given that it's the leading cause of death for decades now in men and women everywhere. So,
Yeah, yeah. Should matter. Since it's still like I said, it's the
and
normal.
I do think it matters. I say that at, like, off the cuff, that's kind of poor form, honestly, because I think this matters to every doctor. Um, it, I think every doctor has seen tragic outcomes with this, either in their professional or personal life or both. And unfortunately, a lot of the data and a lot of the practices has come from population-based medicine. That's just tough to pin down when you're not looking at like an individual's risk factors, right? So like the typical like ASCVD, plan of if you go on a statin or not, just doesn't take any of these other things that we talked about today into account. So it's just a little tricky to navigate those bars.
Totally. I like, yeah, I think we kinda talk tongue in cheek, but it's about, like, I mean, it's a medicine's a rough world out there, and it's really
Yeah.
easy from to be, I mean, I'm the poster child of this deal. Like, so at 40, I had a 10% left main lesion that had a 0 calcium score, right? So, I have a really bad family history of coronary artery disease. Like, my dad had a, 5 vessel bypass at 52, his dad died of a heart attack, and his dad died of a heart attack. So we're scanning me early, right? I mean, now
Hmm.
that was 5, 6 years ago. 6 years ago now, I'm dating myself, I'm 46, is, like, we would have probably scanned me even earlier if we had this capability, right? We would have scanned 35. So I had a 10% lesion. This is my point, is like cardiologists, I have cardiologist friends. I have many friends. They're good people, but, uh, they we, they were like, "Eh, whatever." And, like, we're more like, "No, that's a 5-alarm fire. You have a 40-year-old male with a left main plaque. Yeah, my calcium score is 0, but I have plaque." And so we were able to aggressively manage that, and now 30% of that 10% lesion got converted to calcium in 5 years. We now know we should have followed up on me sooner, but we didn't have that data then. Um, and now a and so 30% of that 10% lesion is converted to calcium. Right? And this is another example of why calcium scores suck is I now I have a positive calcium score, even though I'm way more stable from a plaque burden standpoint, right? But now I have a positive calcium score. Like, oh, okay, like, um, but it's amazing though that we can now do this and completely stop progression. Where I'm 7 years out from when my dad had a 5 vessel bypass. Like,
Yeah.
big deal. Um,
And not only that, but we can monitor which treatments did that, right? And
yes,
see if they worked.
yes.
So, yeah, so it's all about early detection and monitoring what works and pivoting when it doesn't, right? So, that's the name of the game and why we like to get data.
Totally.
So, awesome. I think that was a lot of great conversation on cardiovascular disease. Is there anything else that keeps you up at night about cardiovascular disease that you would like to share?
Oh, that keeps me up at night?
Or just that you find really fascinating or helpful, prudent?
I mean, I might be leaping ahead a little bit, because I think from an inflammatory standpoint, I don't think, like, we had a lot to offer people as when we're talking about, okay, cholesterol burden, endothelial dysfunction, we're working on people's blood pressures, we're working on glucose control, all these things, but from an inflammatory standpoint, yeah, omega-3s is a part of that picture. There's other things like dietary things and exercise and all the sauna and all these things that we can do. But from an inflammatory standpoint, what we were offering people historically wasn't that great. Like it was like,
Mhm.
maybe and we would lower CRPs on people, and that's great. But what's changed in the last however long is, I guess, a year and a half, 2 years, I would say, is GLP-1's, receptor agonist, and the component that we think now is there's an anti-inflammatory component to this, whereas, when maybe I probably said this to you, I'm guessing you felt the same way. When GLP-1 meds came out, I was just like, "Oh my god, I can't believe we're doing this as a society. This is what we're doing." Um, and then everybody's, like, handing them out like candy, and everybody gets a GLP-1, and then there's a bunch of side effects. But then we started seeing that data around decreased cognitive decline, and we start seeing data around reversal of plaque burden on people or plaque stabilization, and we find that there's, like, an anti-inflammatory response at a neuron level and a vascular level. Like, I didn't see that coming. I don't know anybody who did. Maybe somebody did, and it's a lot smarter than me. I'd love to meet him. If you know him out there in the podcast world, please introduce me. Um, but I think, that has been the big change where now on people with low density plaque, I'm definitely putting them on, uh, at least low dose GLP-1s, microdosing GLP-1s.
Yeah, or even a lot of our, like, you know, ApoE4 patients that are at risk for both cardiovascular disease and dementia for multiple reasons. It reduces risk. There's pathways in terms of mental health, so there's a big tie in there and dopamine pathways. They're in addiction. There's emerging evidence for autoimmunity and benefits in immunomodulating properties for similar reasons to what you're talking about now, in a different capacity. So there's so many different like applications here. I think what's fascinating is like how much effect I can see at like micro dose of these meds compared to what a lot of people are taking for weight loss. And also just like it is like the perfect example of using like nuance and discernment, right? Because there's so many different applications of this. Like this is a very different conversation than like a 6-year-old being recommended this drug without any lifestyle changes happening, like, it is a very different, like, just philosophical conversation, which we don't even need to dive into. I think it's kinda obvious to the listeners. And there's some, like, apprehension, around, like, how massively these have rolled out, and who's to gain with that, in certain populations, but, like,
We're gonna go into big pharma because I wasn't planning on going to big pharma today.
let's not. Massively prefer not to go into that. I'm just sharing that, like, I think it's a really great example of, like, how let's not throw the baby out with bathwater, right? Like, there's a lot of good here, and there's an incredible data coming out and continuing to come out on these drugs, that can just have, like, massive implication aside like, independent from the weight loss benefit, which we know applies to almost all these things as well.
Sure, and I think, yeah, the GLP-1 agonist specifically around, like, cardiovascular disease, but, like, I'm is great, but, like you say, you pull back and it's the whole picture. I'm fascinated, like you said, like, around the dosing and the scheduling, like,
Yep.
every 7 days. made up time frame, right? Like, um, some people are a little they're doing bigger dose more frequently. Some people are doing tiny doses like 0.5 milligrams of terzepatide every 10 days, because they're but we're but what we're seeing is as you go on lower dosing and you use these other more nuanced metrics around like food noise, looking at weight loss, following, like how people generally feel and having that adjust people's dosing, that it results in this like probably slower, lower level weight loss and glucose control that if you get people off these medications ends up being more sustainable in the long term, right? As opposed to it being this sudden, like, let's just hammer people, have them lose a ton of weight, a lot of muscle, and then take them off the meds and have them rebound and probably gain more fat back than they did have than muscle. And then they're in a worse situation than they were. But I think this low level like anti-inflammatory effect is you asked like what makes me like think around cardiovascular disease.
Hmm.
That is probably the biggest change in the last 2 years around my management with
Yeah.
it.
Yeah. It has been something that we haven't had a lot of actionable inputs other than like reduce inflammation with lifestyle, like you mentioned, right? Which people are trying to do. So cool. The only other topic that I'd love to touch on, so we talked kind of roundabout ways about mental health and the effect it can have on, general quality of life, but as well as just increased risk of mortality and all these other just diseases, including cardiovascular disease, right?
Yeah.
Um, any favorites in terms of, how to manage these things? Because I don't think it's a secret that like the common therapies, the common model of what leads to things like depression is kind of been recently turned on its head. And therefore the therapies, it's not a huge stretch, haven't had like the best rates of remission. I think it's what, like 30% for SSRIs in remission of major depression. So, and I think lower for treatment resistant. I mean, that's kind of intuitive, like obvious um, in the name. But but what are we like? What can you do? I mean, yes, we want to improve their metabolic health and their micronutrients and their inflammatory levels because all these things play a huge role in mental health. But like, there's some pretty rad things that you can directly do. I'm just curious what your favorites might be and what you've seen like really work in your
Yeah.
patients.
Yeah, I mean, like you said, like, I mean, it's funny, like, SSRI studies and medication studies, you think like we were back when I was in medical school, um, uh, feels like a long time ago, but if you had a drug that had a better than placebo, uh, effect, you were crushing it in a study, like, right? I mean, but now we're talking about for me, it's psychedelic-assisted therapy, um, and, the above board, legal way of this, is, ketamine-assisted therapy, um, and I we're looking at studies for ketamine-assisted therapy of a recidivism rate, so no symptoms at 1 year, in some studies as high as 80%, anywhere from 60 to 80%. Doubling or over doubling, efficacy, like, is mind-numbing. It's insane, right? Um, and that, like, I think that's the most exciting thing. That's where I've had the most success with people, actually with de-prescribing with people on ketamine-assisted therapy. I certainly have had people who've gone out and they've done, MDMA, psilocybin, other types of modalities, and done really well. And so I that like for me, like that's like it's been kind of amazing to see the transformation in some people around these
Hmm.
therapies. I think, yeah, I guess I would say that's my. Yeah, I know there's other things that are cool going on, but for me, that's the winner.
Yeah, for sure. And there's massive amounts of research going on in this, and it's becoming more and more accessible. I think what's really cool about how it's becoming more accessible in kind of standard medicine is that not only are we going to be able to get more data, but like people are going to be able to have like appropriately facilitated scenarios, which when you're talking about serious trauma is so important. Um, rather than, just going to South America and, having who knows. Um, we'll leave it there. But
Shoot,
you know,
it's usually ayahuasca, and they felt the calling, and people didn't know what they were getting into when they went down there, and they're like, "Whoa."
yeah, maybe people had a great experience, but I have a number of patients that there's no way I would recommend that sort of scenario in any capacity, even if it was like illegal and in the US, because I think people need to be able to have the skills and support to handle whatever comes up in
So, I
these
mean,
scenarios.
totally, and when I say psychedelic-assisted therapy, that's exactly what I mean, and but setting people up
Yeah.
with the right setting, setting their intentions, knowing what you're going into, and then also the follow-up plan around integration, and that's such a crux part of this. What I think is gonna be interesting, and I actually think this is a Carl prediction, you can say what you want about it, I actually think AI is gonna play a role here. Um,
Mm,
what I think's
say
gonna
more.
hey, oh, say more. What I think's gonna happen is so this is very complex. Um, there's a lot of different modalities that are considered psychedelic-assisted therapy. There's a lot of different, people out there that have depression, trauma, PTSD driven. Uh, they have more OCD or they substance abuse, other mental health disorders. And at the same time, there's things like psilocybin, which have a billion different strains, right? And that the we don't really know how psychedelics work. I mean, we kinda do, but not really. Um, but what we're gonna be able to do is look at these neural networks and be able to tease out with AI what medication regimen makes the most sense given a person's, picture, clinical picture. And there may be some neural wiring that we can track and MRI, like SPECT scans and things like that, that we can say, "Oh, this is that person that is gonna respond best to this treatment." And I don't think it's that far away, um, especially when we start to look at different strains of psilocybin, and it's like things get really complex where humans can't handle that data.
Yeah. So cool. Yeah, I mean, the data is massive on psilocybin compared to really just blows, really any type of psychedelic assisted therapy that's been studied, mainly ketamine, MDMA, and psilocybin. I think are the big three. The results just blow like traditional pharmaceutical interventions for depression and these other mental health disorders, PTSD, et cetera, out of the water. And so it's exciting to see that there's going to be a lot more research, application, and cool AI applications. Apparently, I didn't know about all the psilocybin strains, so I should probably. That's good to know.
There's a lot. I don't think there's stuff
Yeah,
going on out there. I don't we don't even know what's going on out there, but yeah.
yeah, yeah.
Then
Sweet.
do you wanna talk to me about stellate ganglion blocks?
Yeah, we can quickly go over that. So I'm super fascinated about the intersection between the nervous system and health. Obviously, I see a lot of autoimmune patients, and there's a massive overlap there with nervous system dysfunction, early childhood trauma, or just traumatic history in general, PTSD diagnosis, etc. This also started coming on the map for me post COVID because of the dysautonomia that can happen post COVID for some individuals. And other viruses as well. COVID's not like super special. It's just a little, a lot of people had COVID all of a sudden. So we started seeing a lot of it. But, when the nervous system gets dysfunctional, a little bit of a reset, can have, like, massive implications for immune health and for, mental health going forward. So there was a study I think that showed, like, a 70% reduction in PTSD following a stellate ganglion block in military. personnel with a history of PTSD, which is super fascinating. And these results can last a while, so months after. And I definitely heard multiple anecdotal reports of people that are like, wow, I walked in one way and I walked out another after a quick intervention. I just want to like always put an asterisk by stellate ganglion block. It's a procedure
Yeah.
and it's in the neck, and there's a lot of super important architecture in the neck. So it's not something to be taken super lightly. The risks are present, and I think the proceduralist should be very clearly vetted,
Yeah.
by somebody that you trust. So that's the big asterisk I like to put on that one.
Sure. You want somebody who's done a billion of these and does them, teaches them, and then also does them and it's, guided and yeah, well managed
Yeah,
for
yeah,
sure. This is great.
cool. I loved it. But I like that there's like cool, actionable, concrete things that have a better than 30% success rate that you can offer people because there's such a massive implication with when there's a mental health disorder or undiagnosed and people just like aren't feeling good, both for quality of life and as well as the impact on health. So these things are cool. I think they should be talked about more. Um, it was great to catch up.
It's good to talk with you. We haven't done a podcast together. I don't when's it have we done a podcast
I
together?
don't know. I don't know. I don't
Um,
know. I feel like we just talk about these things a lot, so feel really comfortable.
yeah.
I don't know if we've done it on the podcast. So,
Alright. Well, maybe you should bring me back more. They don't like now that I'm CEO, that people don't bring me on anymore. They don't wanna talk to me anymore. Yeah, too
we'll
many.
bug you about plenty more.
Oh,
So,
that's great. I like that.
awesome. Good to see you. Good to talk about 2 of the blocks of Healthspan, and we will talk about the rest soon.
Alright. Take care.
All right. Bye.
Bye.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.